Hi, everyone. As Kate mentioned, my name is Melanie. Okay, so yeah, I'm here today to present on supportive care pharmaceuticals, really related to any cancer therapy, but I will try and focus specifically on pancreatic cancer as well. And as Kate mentioned, my clinical position right now is in oncology, medical oncology, inpatient care. So I have no conflicts of interest to disclose. I do receive honorariums for presentations to various people, education centers, and different healthcare practitioners. And I do want to recognize right now that I'm presenting from the Mi'kmaqi, ancestral, and unceded territory of the Mi'kmaq people, Nova Scotia, and I think that's something to recognize and speak to. So we're going to talk about some major kind of themes throughout this presentation. And it's just that all pancreatic cancer patients require supportive care, and all cancer patients require supportive care throughout their journey. So we're going to discuss things like nausea, fatigue, pain, depression, and we'll talk about those over-the-counter medications, or what people refer to as natural medicines as well. And I will touch on cannabis briefly. I do have some disclaimers. One, I'm from Canada, so I will be speaking to the drugs that we use and the medications that we use here in Canada. We follow certain guidelines that are Canadian, so most of the things I'll be speaking to will only include those medications. So I apologize if I'm missing a couple that you might be familiar with. I also use only generic names, so I don't often use a brand name. That should make it easier, hopefully. And then we do have different laws in Canada for some things, so that might come into play for the cannabis discussion a little bit. I just wanted to bring that forward. And as I mentioned, I'm only going to be speaking about as medications in generic, the names as well. So just a little bit more about cannabis specifically and our laws in Canada. Cannabis is legal in Canada, and we also have like kind of a subset of that as well as medical cannabis, which is prescribed by a physician. So I am going to touch a little bit on that kind of stuff, but that might not be applicable to all countries. And then I'm also not an expert in I would say pancreatic cancer. My patients tend to be right now sarcomas and gynecological malignancies and stuff. But these things that we're going to discuss today are broad themes for all cancer patients. So they really will be applicable for everyone. I'm going to spend 6 different sections with you guys talking about medications, but medications can kind of be intense sometimes to talk about. It's a lot of information, and it can be confusing and lengthy and really dry, really. So I'm going to give you lots of time for questions. If you have anything, as Kate mentioned, you can put it in the chat box and Jessica will stop me. But I will also give you 6 different times that you can ask questions about those topics that we reviewed, just so that if you have anything, hopefully I can answer it. And then at the end as well, if I can't answer a question, because sometimes, I need a resource and I might not have something with me right here, but if I can't answer a question, feel free to ask Kate or Jessica in the chat box. And even if I don't know the answer at the end, I can easily find it for you. We have lots of resources. I just can't do it while I'm on my presentation screen. So today's subjects and objectives is we're going to review first nausea, then we'll talk about fatigue. We're going to review pain management medications as well, bowel changes, mental health, and then cannabis, as I mentioned. Each subject, we're going to talk about medications, kind of things to look out for them. And then also we're going to discuss some non-pharmacological methods as well as what people consider natural health products. So we'll go over all that stuff as well. And I want to just highlight right now, the non-pharmacological methods for dealing with some of these things are also extremely important and not to be taken lightly. When I counsel a patient, I always make sure I focus on that stuff too, because general overall health is really balanced by medications and non-pharmacological options as well. So I have a bunch of pictures of dogs throughout. As I mentioned, I find Sometimes people can get a little bit overwhelmed with medications or medications talk because they just can be kind of dry. So, we'll just break it up with a few happy pictures of puppies and dogs because I like them. So first we'll discuss nausea. Everyone that goes through cancer treatment will experience nausea from one thing or another. The causes can be many different things, and those causes can actually change throughout your therapy or your journey with a cancer diagnosis. So it can be the actual diagnosis itself. It can be the medication to treat that diagnosis, such as chemotherapy or radiation therapy. You can also get nausea from supportive medications that you need, such as pain management medications or the actual pain itself. Constipation causes nausea as well as anxiety. And then some other things that happen within your body is the electrolyte imbalances that can sometimes occur post-therapy or due to the disease state. And then heartburn and gastric reflux disease or esophageal reflux disease, or GERD, if that's what you want to call it. Those can cause some nausea as well. Chemotherapy-induced nausea, there's generally three types. There's acute nausea and vomiting that happens within that first 24 hours after chemotherapy. And that nausea and vomiting is usually handled pretty well by medications that are part of your cancer therapy or chemotherapy protocol. They often get hung as along with the chemotherapy prior to the start of your chemotherapy agent. And then you usually take pills like once a day for 3 days after, or twice a day for a couple days after, something like that. For us at our center, though, that type of nausea and vomiting is very well managed because we take kind of pride in making sure that patients feel very comfortable. We really want people to feel as comfortable as possible. So those medications, we think long and hard about what we're giving. And then if they're not working, we're quick to make some changes and alterations in different types of medications to support you through that part. There's also delayed nausea and vomiting, and that occurs usually 24 hours after the chemotherapy or a couple days after the chemotherapy. And they can be supported as well by those medications that go along with your chemotherapy protocol. So those would be things like dexamethasone, ondansetron, or metoclopramide. Sometimes people use prochlorperazine, and I'll go over all these things in a minute. And then usually you get an as-needed medication, one of those agents as an as-needed medication, and they usually work quite well. People still feel a little nauseous sometimes, but we usually can control the vomiting. We don't want anyone vomiting because of the complications that come with that. So we try really hard to focus on that with our protocols. And then there's actually something called anticipatory nausea or vomiting, and that occurs before the chemotherapy. So what happens is your body is going through this cycle where every 21 days it gets a treatment, let's say. So after a couple times, your body has realized that when you show up to that specific treatment center, maybe there's a smell or there's a site that it triggers the chemo trigger zone within your brain that will make you sick before you have been even given an agent to make you sick, which is a very interesting type of nausea and vomiting. And that's actually treated a little bit differently. So we're going to talk a little bit about that as well. So this is complicated, and I don't want you to feel overwhelmed. The rest of the presentation isn't going to be super complicated like this, but I really wanted to show you a couple things so that you could kind of see, because nausea and vomiting isn't as simple as just treat it the same way for everything. So that's our brain, and then you can see down there in the right-hand corner is our stomach or our guts, and right there is our vomiting center in our brain. So this is a higher center that I'm pointing to now that talks about thinking that or feeling sick. It's feeding the vomiting center, and you feeling sick because of a smell or an emotion or a sight. So that would be that anticipatory nausea and vomiting that I was talking about. Then you can also see there you could get nauseous and vomiting from your gut or your stomach as well. There's different receptors in there as well that could make you feel sick, and they feed the nausea, the vomiting center as well. This is the chemotherapy trigger zone there, and that's so cytotoxic agents kind of activate that, and then that feeds your vomiting center. So we can think about using that location as a location to target with medications as well. And each different center has different medications. Some cross over to different centers as well. But in the gut, we can use, they call them 5-HT receptor actors. I'll leave it at that for simplicity, or serotonin receptor kind of actors. They work on that receptor. On the higher centers of the brain that are associated with those smells and emotions and sights, so that anticipatory nausea and vomiting, benzodiazepines tend to work really well in that scenario. And then for the chemotherapy zone there, you can use a few different options. So you can work on those serotonin receptors, you can work on the dopamine receptors, and then you can work on this NK1 receptor as well. And then just so everyone knows, we also use 2 other agents for nausea and vomiting, or have been used. One of them we're all very familiar with, and that's a corticosteroid or dexamethasone or a steroid. We don't actually really know how that works. We have some ideas, some good concepts, but there's nothing definite. So we're just going to leave it as we don't know how it works, but it works to act on that vomiting center as well. And then cannabis or cannabinoids, sorry, they also don't have a really well-known mechanism for prevention of nausea and vomiting, but they do work. We don't use them as part of a protocol or anything like that, but there is some evidence that they do work slightly. So the antiemetics that we tend to use, there's a group of them called aprepitant, which is this group. There's a couple different agents that we use in Canada. We use steroids. It's always dexamethasone we use. We use metoclopramide as well. And then we use olanzapine as well down here. And then there's a medication called ondansetron and prochlorperazine. We use these agents in different groups and different ways, depending on the type of chemotherapy that you're getting, and then also depending on what kind of nausea and vomiting you're having as well. Some of them are used as scheduled medications, and then so that you would take them at specific times each day, and then some of them you take them only as you need them. Now, I always like to say all medications come with a risk. So even what people consider natural health products, there's always a risk. Nothing comes without risk in this world, really. So there's always a side effect to be cognizant of and to be thinking about, and if a patient can have a medication and be safe for them or not. So the aprepitants, they work really well. They're usually given for chemotherapy protocols or patients that are getting chemotherapy protocols that tend to be quite they cause quite bad nausea and vomiting. And then they do cause some problems like hypotension, which we do see in patients occasionally. They do cause some diarrhea, some indigestion and headache. And then we have to be cognizant of using them with certain other drugs because they have other drug interactions or concerns that we need to be thinking about. If patients are on some medications like home medications, we're cognizant if they interact with them. We also use steroids that I mentioned, that dexamethasone. People are probably quite familiar with that one. You've heard the word, heard that medication or used it. It does cause some interesting side effects. It causes hypertension, which is different, so higher blood pressure. It does cause insomnia, and I will say I've had many patients tell me that they have had, while they're on the dexamethasone, they feel really good. They have a lot of energy because they're up at 3 o'clock in the morning washing the walls or out in the woodshed making, bird feeders or something like that all night long. But then there are some concerns with that medication too. It does cause hyperglycemia or unmasked mass diabetes for some people. It can elevate their blood sugars. It increases people's appetite, which is a good thing. But then in a more challenging note, it does cause some mood changes. So it has documentation, and I've actually seen it a few times, where a patient can become quite aggressive while they're on the medication. Now, that typically arises if they're taking a little bit of a higher dose and they are on it for a longer term than just around their protocol for their chemotherapy. So that would be for something a kind of longer term, basically. But it does cause mood changes for people, and in that case, we have to stop the medication because it can cause psychosis and stuff. It does have some concerns around heartburn. It gets you kind of get a nasty stomach from it, and sometimes people get put on what's called a proton pump inhibitor or a PPI or something to calm their stomach while they're taking the steroid as well. It doesn't really have any drug interactions that we need to worry about per se, but a pharmacist or your medical healthcare team would always be looking at that as well. Metoclopramide is generally well tolerated. It does cause some changes to taste. People tend to get a headache on it sometimes. And then in more concerning issues, it can cause some movement issues, but that's very rare. You do not want to use that medication, though, because of its other effects and where it acts as a antagonist or an agonist on the receptor. So where it acts in the body, those receptors can also do other things. So you wouldn't want to use it for someone who has maybe Parkinson's or someone who's on an antipsychotic. We tend to hold it on for our patients who are on olanzapine, and then you would never use metoclopramide and prochlorperazine together. We also use a drug called olanzapine, and that tends to cause things like hypotension. It can cause indigestion. I apologize for the extra S there. It is considered a second generation antipsychotic, but it has some good properties for preventing nausea and vomiting. You would take it twice a day in that instance, and you only take it for a few days, typically speaking. But the one thing that we often are concerned ourselves with that this medication is any ECG abnormality. So it can cause some things to your heart. It can prolong one of the how do I explain this? It can prolong one of the periods of heartbeat, and that is always a concern. And certain medications can do that, but we have other risk factors as well that can do that for people, such as being a woman. So as a healthcare professional, whoever prescribes that drug and then fills the drug for you and monitors you on that drug, they're always thinking about those kinds of things as well, about how it's going to affect your body as well. The other medication that's underneath there, and I apologize, you can't see it. It's called ondansetron, and or people refer to it as Zofran. It's a very common medication used for nausea and vomiting. It works on the 5-HT receptors as well. The comment I get the most about ondansetron is people don't like it because it can make them a bit constipated. It does kind of do this thing where it dries up your system a little bit and make you a little constipated. We do think about that medication as well when we're considering people with cardiovascular issues or that QTC prolonging issue that we're worried about. So we think about that as well. So just to review the brain again, and I want to talk about gravel a little bit. So that medication that I just put up there in red is also called gravel. I'm sure most people are familiar with it. It's a common medication used for nausea and vomiting. The mechanism of action is not actually well understood for gravel. They do think it may work in the GI tract, so down in your gut center there, but also really in your vestibular center. So I'll see, I don't know if I highlighted it. Oh, in your gut. Oh, there I did. Look at that. It showed up, so that's good. Yeah, so in your vestibular center there where it's working on motion and that kind of thing. It works on that. It doesn't work in chemo-induced nausea and vomiting, but some patients really like how it works. So, we always work together with the patient to find a medication that works best for them, and talk about options. So it doesn't really have a place or a role in chemotherapy-induced nausea and vomiting, but maybe for other types of nausea and vomiting. So that table is also very complex. You can see it all, which is a plus. There's a lot of medications on it. It talks about how they work. It talks about different kinds of forms. It talks about some serious adverse effects or regular things that you would see if you were to take it. And then it talks about QTC prolongation. And I just wanted to highlight this. So as your healthcare professional is reviewing all these medications with you, we're thinking about the big picture, and we're also thinking about what makes sense with the other medications you're on. So we're considering all these options when we're talking about things. And then I also thought it would be good to put something like this on, not because I expect you all to like study it or really value the information in it, but I think really what's important to see is that there's lots of options, and we always think about your options, and with any kind of medicine, if a particular agent isn't working for you or you're still feeling sick, we really like to find a new alternative for you. So what are some non-pharmacological methods? As I mentioned, they're the kind of the bread and butter, what we want to be talking about. And I always tell patients, so eat what you want. After you get a cancer diagnosis and you're on chemotherapy, it's really important to keep yourself eating, and you shouldn't be limiting things or going through these mass changes in your diet at that time, because you want to eat kind of your comfort foods. You also want to think about staying away from your comfort foods when you are nauseous, because then you might associate being nauseous with eating those foods and not being able to eat anything at some point. So you kind of have to have this nice balance. There is one thing I'd like to highlight, and that is to stay away from fatty foods or fried foods or too spicy foods or too sweet. And that's just because anything in too much is not good. So it's too fatty or it's too fried or it's too spicy, it's not good. So you kind of want to stick in that middle kind of bland foods. And as I mentioned, you want to kind of, eat your comfort foods, but be aware when you're really nauseous. My most important thing I say to patients is try to graze like a cow. So you want to eat small meals often. That's really important. If you get too full, you can feel nauseous. And if you get too hungry, you can feel nauseous. So it's ideal to make sure that you kind of just graze like a cow all day long. When you get your meal, pick at it, eat it over a couple of hours, or eat a few small meals throughout the day instead of those 3 big heavy meals. You also need to really stay hydrated. If you start to get dehydrated, you can feel nauseous from that. So it's really good to keep that balance. You want to drink small sips often. So you really do try to get that 6 to 8 glasses of water in a day. And then I really like the idea of cooking when you do feel better, or when you maybe have a family member helping you out. When you cook some meals and you freeze them in little portions, so you don't eat an entire roast one day, but maybe you cook it and then you cut it up and put it in little portions, and then you can pull it out when you're feeling like that particular meal, and you don't have to worry, because sometimes cooking can actually make you feel really nauseous, the smells and stuff, and then because of that experience of feeling nauseous from cooking, you don't end up eating the meal. So it's important to have options when you're not feeling well, or if you don't want to cause any nausea or vomiting symptoms to appear. And then in reality, you shouldn't be nauseous for more than 3 days, and it shouldn't keep you from doing important things for yourself. And you really don't want to be vomiting more than twice a day at all. If any of those things happen, you need to talk to someone about it. And it just might mean that we change the medications to better balance your regimen for you, or those supportive therapies as well. So that's the little doggy pictures. All the doggy pictures seem to have made it safely through the presentation. But I don't know if you have any questions about those medications specifically, or nausea and vomiting right now. So next we'll talk about fatigue. Fatigue is very specific and it's different from person to person and how they feel. Chronic fatigue may not get better with rest, and that's a very interesting concept for people because usually you think, oh, I'm tired, I should have a rest, and that works really well if you're if you're experiencing fatigue acutely or like all of a sudden for a short period of time. But if your fatigue is lasting for weeks, resting actually isn't always the best option because you really need to make sure that you're balancing that sleep versus rest and ensuring that when you are laying down you're getting quality sleep instead of resting all day long and then not getting quality sleep at bedtime. The causes, it can be multifactorial. So it can be from the cancer diagnosis itself. It can be from the treatments, actually. So those specific chemotherapies or targeted agents can cause some problems with fatigue. But then it can also be for your supportive medications. Not dehydration or nausea can cause fatigue. Not enough exercise, which is interesting. If you're fatigued, people tend not to exercise, but then not enough exercise actually causes fatigue as well. Your age and your mood is obviously part of that those issues as well. The symptoms are people tend to feel, they say they're exhausted, but it really is a feeling of feeling heavy. You don't feel like doing normal things anymore. It's really hard to get that kind of get up and go that we usually feel. And then the other thing that comes with that is challenges in concentrating, and that can be quite frustrating for patients. So, what are the non-pharmacological methods? They tend to have really good benefits. It's these types of things that make the biggest difference. So, make a list of things you need to remember. So, appointments and stuff like that. I mean, I can tell you that right now in my life, I'm really busy. I have 2 small children, and I do apologize if they come running through and you hear them. Sometimes it's hard to hold them back, but I'm, working. I have 2 small children. I'm in that stage of my life where I'm busy. I need to make lists because I can't remember to do things. They really help, and they do take this stress off you as well if you don't have to worry about remembering to do things, which can be beneficial for someone who is feeling chronic fatigue. As I mentioned, you really want to balance that sleep and rest. So you don't want to be laying in your bed all day watching TV because then when it's time to go to bed at night, you're not going to be able to go to bed because your body doesn't realize that it's now bedtime. It's a good idea to have that really good balanced bedtime routine, which involves, they say no screens at your bed. So your room shouldn't have a TV. I know a lot of people do use the TV to kind of zone out and go to sleep at night, but it shouldn't be for a long period. So no more than 20 minutes. You shouldn't be eating too late at bedtime as well. You won't want to have a really big meal before bed because it can not only give you some weird types of dreams, but it'll make restless sleep. You want to think about maybe exercising a couple of hours before you go to bed, having a walk after supper, those kinds of things. And then your room shouldn't be too warm at night. It should be kind of cool and not too many pillows on your bed as well. It seems to be that eating small meals actually works for many things. So eating small meals is also helpful for that feeling of chronic fatigue and, heaviness that comes after a meal. So if you avoid that and just keep your belly full, but not too full all day long, it seems to have a better balance for that feeling of fatigue. You want to stay hydrated. That's very important. You don't want to overdrink. I should emphasize on that as well, but 6 to 8 glasses are really important. And it would be shocking for you to think about because a lot of the times we just don't do that as humans. The other thing that can really help with chronic fatigue is mood support or counseling and meditation. So those things are actually quite effective with mind wellness, and that can help with the feeling of fatigue. Acupuncture has been shown to be a benefit. Exercising regularly, not really intense workouts, but things that get your body moving a bit, and then also things like yoga. I always suggest to my patients to make a diary. And the reason why is for many things. For fatigue, it works really well because you can make a diary on your mood. It can make a diary on the foods you're eating, the rest you're getting, and then your exercise as well and how you're feeling. And the reason why is it's really quite handy to go back and read or rate your things, or read the ratings you've given things. So let's say, you go in to see a healthcare professional and you're telling them that you're really tired, you're just feeling really tired. But then if you would have had a diary, maybe you would have noticed the last month you were actually really tired, and you can say, I only did this many things throughout the week for these 2 weeks, but maybe you actually were doing more than you think. And maybe you were getting out and doing the things you weren't, and you were rating your day successes as more like 4s out of 5s instead of 2s out of 5s. So it's kind of good to just give perspective and go back and see how your day to day you really were feeling, opposed to just in the moment. I also think it's important, and I tell patients, is to save your energy for when needed. So let's say you're going to have a visit from a family member, and you want to, you want to be a little bit more lively. Then it's a good idea to have some more restful periods before that, so you can have that energy for when you need it. And then don't be too hard on yourself. Everyone faces challenges, and it's really important to, take it a little bit easier on yourself and let people help you when you need help, or just let people help you because people want to help. So cancer-related fatigue, the number one thing we need to do is actually improve those contributing factors. So things like low blood, so we would give you a transfusion, dehydration, not drinking enough water. We could give you fluids, but we would also ask you to increase your water intake as well, or fluid intake. Electrolyte abnormalities, those are things we check for when we're doing your blood work, and we would rectify that with supplements as well. And then controlling your pain as well, because you can feel quite fatigued from pain. The pharmacological interventions are lacking evidence, to be honest. So there's 3 agents there I listed. They really offer no real benefit. It would be nothing that most people get. They're given to patients for very specific things. What we do is we improve those contributing factors to your fatigue, and those seem to make the biggest difference. There are some things that are indicated when specific issues arise. So you could be feeling fatigued because you are experiencing a lot of anxiety or possible depression. So we would use antidepressants in those situations. We would use testosterone for certain situations when patients are lacking testosterone. And then if the pain was really challenging, if you were having fatigue because you were in pain, we would treat the pain with opioids and steroids as well for other things. With regards to natural health products, to me, I really just call them medicines, because they are just medicines, but you can just buy them over the counter, and they're not regulated the same way. The only ones that show any sort of evidence are ginseng, and sometimes people use things like vitamin B12, or one of them is, it's called Yi Gong. So those agents, there's not a lot of evidence to say they work. And we always caution people about using medicines that aren't necessarily regulated the same way, or have the same level of evidence. And the reason why is because they haven't been studied to the same depth that the prescription medications have. So we don't have the evidence to say they work, but more importantly, we don't have the evidence to say that they don't do something that could interact with a medication that is required. So sometimes these natural health medicines that people take, they can do things like boost your immune system, but maybe we don't want to do that for another reason, or they can do things like cause bleeding problems, or work against what we're trying to do. So we try to be really cognizant of that kind of stuff as well. So this is another little doggy playing a guitar, which I thought was really cute. And I don't know if anyone has any questions.
Could you go back to one slide? The ginseng, I found if somebody has got high blood pressure, it is not good for them. What is your thoughts on that, Melanie?
Yeah, so yes. There are a lot of reasons why I stop medications like that, and ginseng would be one of those reasons. Anything that works. So of these medicines, these natural health medicines, and anything that works in the cardiovascular system, I can be a little bit weary of, especially because a lot of the medications we do cause hypertension or hypotension. So like they mess with your blood pressure. I am very cognizant of them when I am talking to patients about them. I also feel it's really important to balance someone's desires as well. So if someone is interested in a medicine such as ginseng and find it's really beneficial, we'll do things like increase monitoring for them. So we try to work with patients with regards to these medications while educating them at the same time, but we really want people to feel heard and valued when it comes to these kinds of products as well, because maybe they do make someone feel better. And I know, and I want a patient to feel supported in that way. And then we'll move on to pain. So pain is it's a pretty challenging topic. There are different types of pain that we can consider. So there's somatic pain versus visceral pain. Somatic pain is that pain that we all identify as pain. So it's like if someone pokes you with a needle, you know where the pain is coming from. You know that feeling. It's a sharp, it's an instant pain. It's on the muscle or the soft tissue, soft skin tissue. Like you cut a finger. The visceral pain is the pain that's a little bit more harder to identify. It's more of the pain that happens in our bodies from our organs, like our guts and stuff. It's vague. We can't really localize it. It's more challenging to treat because of that. The good thing about pancreatic cancer tumor pain is that it's usually centrally located and in the mid to lower back, and we seem to be able to manage that not too bad compared to other pain syndromes. We use things like stents and blocks, and then also steroids as well for that specific type of pain. When we're talking about the different types or the different ways to manage pain, it's a holistic approach, as it is with many other types of cancer therapy, supportive therapies. So you would use physical treatments such as heat and rest. You can also use acupuncture. That has been shown to help some patients. You want to think about those psychological treatments as well. So it's really about being mindful, trying meditation, Tai Chi. Actually, I will say that specifically when my father became ill, he started Tai Chi, and it was really quite something for him. And then cognitive behavioral therapy, or CBT, as well. And yoga is always a great thing to practice. It's because it really works on that mindfulness and meditation as well. There's always pharmaceutical treatments, which is where I come from, and that's medications and drugs. And then also injections. You can use blocks, and that's something that we do with people with pancreatic cancer. So the first thing there is these are over-the-counter medications or non-prescription medications. You can see it says acetaminophen. Acetaminophen is really well tolerated. There's very little side effects, if any, that happens from it. We don't use it in people who have a compromised liver function, or we use a little bit of a lower dose. There is a max daily dose for acetaminophen, and that's very important, and it's written on all acetaminophen boxes. It says max daily dose, and it would say 4 grams or 4,000 milligrams. The problem with acetaminophen is, since it's such a great drug, it's in a lot of combination medications. So when like Tylenol 3s has acetaminophen, some like Robaxacet, there's a bunch of different muscle relaxants for your back, but they always come with like acetaminophen or ibuprofen or aspirin, actually, I believe. Anyway, you have to add up all the different acetaminophen that you're taking to make sure you're not going over that max daily dose. So that's really important. It's a great option. And then there is some evidence to say that the Tylenol arthritis, which is a controlled release formulation, so it's the exact same thing as Tylenol, or Tylenol extra strength. It's the same drug, but it's given in a different method of release in your body, which is interesting because you don't have that super high peak of benefit from the drug and then the drop down. It kind of keeps it more steady. And there are some studies, and I can say this myself, I have had actually quite good results with patients when they switch to Tylenol arthritis from, let's say, an NSAID or actual regular strength Tylenol or extra strength Tylenol, and they feel that they have better control of their pain. It's a medication that you take 3 times a day, and you do have to take it for a couple of days to see that benefit. So the next one that's written there is NSAIDs, and underneath it is the common names that you would hear, or the drugs in that class, such as ibuprofen, naproxen, or aspirin. They do come with some risks, unfortunately. They cause some stomach upset, and they do make or they can act on the function of our blood that does clotting, so they can make you bleed a little bit more. Sometimes the drugs are given with things to protect your stomach as well. And you need to use it in caution with patients with cardiovascular disease or any sort of decreased kidney function, because of how the drugs work. They can kind of create some high pressures on the heart and kind of squeeze the kidneys a little bit, kind of. So we're cognizant of that when we're using those medications. They are actually really good for bone pain or inflammation. So anything that's inflamed or swollen, they work well for that because they're an anti-inflammatory, and they are really good for bone pain. And people actually respond to each of these medications differently. So sometimes you might have a friend tell you that, naproxen is the miracle drug, while another friend say that actually naproxen doesn't work and they like ibuprofen. It's interesting to see that. Seems very patient specific. Aspirin as well is a drug that you can take at a really low dose, so that 81 milligrams or 80 milligrams, depending on what country you're in. At that low dose, it only works as what's called an antiplatelet, so it's good for people who have cardiovascular disease and problems with like heart attacks, that kind of stuff. And it doesn't have any of those pain management properties, but then at higher doses, it has those properties. There's a box called topical medication. So that would be something like Voltaren or Amulgel. So that is a topical NSAID. So it's kind of like ibuprofen or naproxen, and it's topical and you rub it on. It tends to be really good for things like joint pain. Depending on the type of joint, it can be active, or how big the joint is, I guess. It's also really good for like muscle pain or surface pain. It doesn't actually absorb into your system to cause any real side effects per se, but it can cause some irritation to the skin as well. When someone's taking Voltaren, I'm not too concerned about their absorption of the NSAIDs or the NSAID that is used in that medication. So it's kind of a nice add-on, but if it's a really big joint like your hip or your knee, it doesn't really work. But sometimes, on your ankle or your wrist, sometimes people find they get a little bit of benefit from it. So those pain relievers that are over the counter or non-prescription medications, the good thing about them is in each class, so you see there's acetaminophen, and then there's ibuprofen or naproxen and aspirin that are all together. Each class works differently. So that's what's really good. So you can use acetaminophen and an NSAID, either naproxen or ibuprofen or aspirin together. And it's not a big deal. You don't have to worry about taking two medications or anything like that and it being a problem, because they work on different receptors in your body. So you're not getting too much of one thing, which is a good thing. The prescription medications we're going to talk about are things that are almost opioids, or tramadol or Tramoset. So that is a medication that is kind of similar to an opioid or that group, but it comes with acetaminophen attached to it. So as I mentioned, acetaminophen is mixed in with a lot of medications. Then there is just plain opioids, which we'll discuss. There's old antidepressants, and those are things like nortriptyline or amitriptyline. You probably have heard about them. Sometimes people use them for sleep, and then at lower doses as well, people use them for pain. That is a neurological, like a nerve kind of pain. I guess that is the best way to put it. So we don't really use that for cancer-related pain unless it's like a nerve pain. So the tumor is pressing on a nerve, maybe. And then gabapentin is that gabapentin family of drugs. That's a new family of drugs, kind of, and they work on the same kind of thing for that nerve pain. And then new antidepressants also work on nerve pain as well. So you use different pain management medications for different types of pain. So this slide is intense, and I'm just going to show you what is important on it. This is about opioids, and what I want you to see here, and I'm going to highlight them all in little circles, and it's pretty small, so I'll read it out loud to you, is that just because you take one opioid doesn't mean that you can just take another one at the same dose, because each drug has its own kind of dose that's relative to the other drug. So that's what's really important to know about these drugs. And also, just because one has a really high dose doesn't mean that it's more potent or more intense of a medication than another one. So just try and think about it like that. The dosage strength doesn't mean that it's stronger than another one, because each drug has a different kind of ratio of dose. And that if you're going from taking an oral version to a subcut version or a butterfly version or an IV version or an intramuscular injection, all of those things, the dose actually changes. And that doesn't mean that you're getting less of the drug or anything like that. It's just that we have these conversion factors that we follow. And I just wanted to kind of let everyone know that, because sometimes people can get a little confused when we're switching opioids, different opioids, and then also different formulations as well, or different deliveries. So as I mentioned, there's those opioid equivalency dosing things that we use there. And you can see here in Canada, we use morphine and codeine. We use fentanyl, but there's no dosing equivalencies for some things. There's hydromorphone, miraparidine, which we don't use that much anymore. We refer to it kind of as a dirty drug, unfortunately, because it comes with a lot of side effects. And then oxycodone and tramadol, as I mentioned. So opioids, there's codeine or T3s, Tylenol 3s. That's usually how it's delivered. The interesting thing about that drug is it actually needs an enzyme in our body to turn it into morphine, because our bodies need morphine, not codeine. So the funny thing about that drug, unfortunately, is that some people actually don't have any enzyme at all. So you could be given a prescription for codeine or Tylenol 3 and get no benefit from it at all. You could say, I didn't feel anything from that. Or you have too much of the enzyme that's needed to convert that drug into its active form, and you get a way bigger response than you're supposed to. So the drug is a little bit challenging to use, and sometimes people don't go to it as their first choice because of that. It does work really well for the majority of the population, but there is that thing to be cognizant of, that sometimes people don't have that enzyme and sometimes people do. We use morphine a lot. It's the active drug there. And then people also use oxycodone. Hydromorphone is one that we use a lot in the hospital. It's easy to be given as a subcutaneous injection. And then we also use methadone. And methadone is an interesting medication. It acts on more than just that morphine receptor, kind of, or opioid receptor in our body. And it's used for addiction management, which is kind of where everyone thinks that drugs' purpose or place is in therapy. But it also has really great benefits for some patients with cancer pain. The thing about methadone that's really challenging is that its conversion with other opioids is not straightforward. And we usually try to say that other people have tried other opioids first before we switch them to that or add it on. So it takes a little bit more thought, basically, to prescribe that medication. I won't lie, opioids tend to be the best option for cancer-related pain. They're fast-acting, they're effective, and then that stigma of being addicted to opioids really doesn't happen that often, or it's not really that associated with cancer patients. So greater than 90% of cancer patients do not get addicted to opioids, because they work so effectively for pain management and cancer-related pain. They unfortunately do cause quite a bit of constipation. So when someone starts an opioid, it's not uncommon to start another medication too. And I will be the first to say that I actually do not like a lot of people taking a lot of drugs. But this is one of those instances where prescribing one medication means prescribing another one, and it's the appropriate thing to do, for sure, because we don't want people to get constipated. They also do cause sedation, and you can see that happen with dose increases as well. once you're on the drug, and they do slow breathing for some people. And that's why we need some of those rescue medications sometimes for people who are on high dose opioids. Tolerance does develop, so you will notice that your dose does change over the time, but that's okay. It's something to be expected and something that we can manage as your healthcare team. The one frustrating thing about opioids is that they actually have this problem where people say they're allergic to them quite a bit. And that's because when you take an opioid, so the ones I mentioned there, I'll just go over here. I'll show you again. It goes codeine and then morphine and then hydromorphone. There's actually one that goes in there that's fentanyl, but you usually get as a patch or an injection, and then methadone. So if you go down the list like that, I call that the kind of the dirty list. So at the top, codeine is the dirtiest. And as you're going down towards methadone, it gets cleaner, kind of, if that makes sense. So when you take codeine, a lot of people say they're allergic to it, and they say they had a full body rash. And that actually can happen because these particular medications can cause an histamine release in your body. And a histamine release is that problem where you have that allergic reaction, basically. And that's what happens when you take the drug. But that could have only happened with codeine. And maybe you move down your list and you're like, well, I'm going to skip morphine and oxycodone. I'm going to start taking hydromorphone and see if that happens. And it doesn't cause the problem. So it's not that you're actually allergic to the drug. To have a true allergy, we would need to see some swelling of the mouth, some breathing problems, possibly it's associated with intense vomiting, not just nausea, a rash as well that is itchy and raised, and then, or something that's completely separate that would be like blistering of the skin, which is another kind of reaction. So even if you think you might have an allergy, there may be not an actual true allergy, and there's a way to manage it and still be able to take opioids. Oh, it's another dog, so that's great. I don't know if you have any questions about the pain management medications.
I have one, Mel. You were talking about opioids and the enzymes.
Yep.
And so for pancreatic cancer patients, they're usually having to take a lot of pancreatic enzyme replacements. I'm wondering how, how that's going to affect them specifically, just when I heard about the enzyme.
Yeah, so enzyme is just a general term that's used. So the enzymes that you're referring to for pancreatic cancer is the enzymes that are used in our body to break down fats and stuff like that, right?
Yeah.
The enzymes that I'm referring to here is a different kind of enzyme. So just a little lesson about drugs, I guess, is that when drugs enter our body, a good portion of them aren't actually active until a specific enzyme, such as they're called cytochrome P50 enzymes. There's 3A4, there's 2C9. There's a bunch of different enzymes that work at breaking down drugs. So they're just for that. So those enzymes that are with pancreatic cancer that we have to supplement with dietary supplements and pills and stuff, it's different than the enzymes that are used to break down the drugs. So even though they use the same word, it's not the same thing. And those enzymes that we have in our body for drug breakdown or drug metabolism, so either the drug is active when it comes in our body and the enzyme breaks it down and makes it not active and we excrete it, or the drug is inactive when it comes into our body, the enzyme activates it, and then another enzyme comes in and breaks it down and excretes it from our body, which is the normal process of how medications work. Those cytochrome drug, P50 kind of enzyme thingies are a little specific for every person, basically.
Okay, awesome, thanks.
Yeah, no problem.
There was a question in the chat too from Catherine. She was asking, what about headaches with codeine?
So getting a headache with codeine?
I don't know. Catherine, are you able to expand on that?
I get a headache a band like a halo that's right around the top of my head when I take. So I always thought that was an allergy. What is that actually?
So that would just be your side effect from the drug. It's not uncommon to get a headache sometimes when you take codeine, to be honest. And it's just codeine and not the other opioids.
Right. I don't think so.
Yeah. So that can actually happen. And it's because that codeine drug, or like the codeine, is a little bit not as clean as the other ones. I know it's not the right way to explain it, but I think it's the easiest way to understand it. It isn't, it's acting more on other things and requires more breakdown to get it to be active.
Oh, so it's really not helping me that much.
Well, it could be helping your pain. It's just you're unfortunately experiencing a side effect. It doesn't mean that it's an allergy. It just means you're experiencing an adverse event to the medication. So in those situations, just to give you some context, like lots of people vomit. So an adverse side effect is different than an allergy. So lots of people vomit when they're on antibiotics, right? It's not uncommon. They make your stomach upset and you vomit. So some people say they're allergic to them because it makes them vomit, but they're not actually allergic to them. We can manage the nausea and vomiting, but we need that antibiotic for certain bugs, right? So there's a difference between an allergy and an adverse reaction, and what you're experiencing is an adverse reaction. So it doesn't mean that it doesn't help with the pain, because maybe it does help with the pain. It just causes an adverse reaction for you.
Got it. Thank you very much. That helps.
So,
no problem.
Well, for that, would you recommend, like you were explaining, sort of working your way down the list? Should she try an alternative that might not have that same?
Yeah, I would try an alternative. I'd work my way down the list. That's what I would do with a patient that said that. Like, if someone told me they were getting a headache from taking codeine and weren't taking it, I would just switch them to another opioid. I mean, I don't know you specifically, so I can't say that, I don't know why you're taking the opioid or anything, but yeah. I think if you're getting benefit from a drug, but it's causing an adverse event that is uncomfortable, all you need to do as a patient is say that, and then usually the prescriber, typically there is an option. Sometimes there isn't. I shouldn't be always so flippant about that, because sometimes we do not have an option. For example, some bugs or bugs that we get in our bodies only can have specific antibiotics, and we don't have options. But there isn't typically another option that we can choose or try and see what happens. And maybe it works, maybe it doesn't, and we have to go back to the original agent. But medicine is specific for person to person, really. So yeah, we like to give them options. I do, at least. Is that cool?
Perfect. Thank you.
No problem. Okay, so we're halfway through. I'm sorry, I'm going to go faster. And hopefully the slides have information on them. So we're going to talk about bowel changes. And really, there is such a thing about being regular. So people have this idea in their minds generally that, you're a regular, I'm going to use the word poop a lot, so I might as well just get it out of the way, but you're a regular pooper if you go once a day. So that's your regular. You go poop once a day. That actually isn't really true, because bowel habits are very individual. You can poop anywhere between 4 and 12 times a week. Sometimes people poop twice a day. Sometimes people poop every second day. Sometimes people poop only at supper time. There's lots of things that are individual about going to the bathroom. So there's no one real thing about being like regular. And that also ebbs and flows throughout your growth as an human, and as you age and that kind of stuff, and what you're taking for medications. You definitely don't want to feel that full feeling, though. So what we think about for regular bowel habits or healthy bowel habits is you really want to focus on the type of bowel movement that you're having, and that's what really matters. And that is shown by this chart. So it's really important to look at your poop. And I know that's a weird thing to say, but I tell patients all the time, get used to looking at your poop, because it tells you a lot about things. It tells you if you're drinking enough water, or if you're getting constipated and maybe your medications are making you constipated, so you need some supplement therapies to support you through that process. Or maybe you're eating too much fiber or something, and your bowels are too loose. So we always look for that type 4 bowel movement, and it's kind of like a sausage. And then the color also matters, and that's something very specific to pancreatic cancer as well. We want to try and achieve that brown color to our bowel movements. But as you are aware, sometimes it can be more of a yellowy kind of floating type of bowel movement as well. So there are two types of changes that happen with your bowels. You can become constipated or you can have diarrhea. The symptoms of diarrhea are 2 liquid stools greater than 2 times a day. You get associated weakness, skin soreness around your anus, and you also can get dehydrated. And those things are not good. So dehydration when you're receiving chemotherapy or targeted agents is not a good thing to have happen. The repercussions and the different things that can occur are not great. We do have patients who become hospitalized because they get dehydrated, and we also support them through that treatment process as well. So the causes for diarrhea can be chemotherapies themselves or those targeted agents. Radiation can actually cause diarrhea as well. And then antibiotics if you're being treated for a bug in the system or something like that. There is one treatment for diarrhea, and it's loperamide or Imodium, maybe you guys call it that. And we'll talk about that specifically. So the other type of bowel changes you can have are constipation, and that the symptoms of that are fullness, you get cramps, nausea, you feel full, you kind of feel like you're backing up in your guts. Sometimes people feel so full they feel like they're going to vomit. The causes can be the cancer treatments or chemotherapies or whatever your treatment is. Opioids cause constipation, as I mentioned, and we usually give people a stool softener or a laxative or something like that with their opioids. And then, as I mentioned earlier, ondansetron, which is a therapy to treat nausea and vomiting. And the treatment is laxatives. So loperamide or Imodium, which is what you treat diarrhea with, it's a really great agent, but we first have to rule out that the diarrhea is not infectious. And that is because if you do have an infectious cause to the diarrhea and you give yourself Imodium, you're actually trapping most of those bacteria that are causing the problem in your guts. And that is not what we want to do. We want to get those bacteria out. That's usually pretty obvious to a healthcare professional or your team to help you know when it's an infectious cause or when it's related to your therapies. The dose can vary, but typically it's 2 pills or 4 milligrams at the first time you have diarrhea, and then 2 milligrams every 2 to 4 hours until the diarrhea has resolved for 12 hours or till you stop having diarrhea altogether. It varies depending on your clinician and what source you use. This is what we use, or what I use here in Nova Scotia. And we do see patients on this. We do prescribe it in hospital as well for patients who are having severe diarrhea related to their therapy. It's a different dose or direction that's on their box. You can see there's a typo there. There's a different directions on the box, but don't worry, that's okay. Most community pharmacists and people that work in pharmacies know that there's a different dose for cancer-related diarrhea, so just be cognizant of that. There is, however, a max dose per day, and that's important. The side effects are constipation, of course. It does cause some nausea for people, but that is also because you're feeling very sick as well. It does cause abdominal cramps, and you do feel a little dizzy sometimes. If you have liver impairment, we also do monitor some central nervous system toxicities as well, such as being drowsy, dizzy, or confused, because it can do some weird things like that. But at the normal doses that we use, even for this, it's not absorbed into urine system and just stays in your GI tract. So I would like to point that out. Some medicines we use, we take them in through our mouth, they go down into our stomach, it is absorbed into our stomach and then pushed throughout the rest of our bodies. But some medicines actually go down through our stomach and just stay, which I consider, which is kind of like the outside of your body. On the outside of your body, it goes through your guts, all through your intestines, and out through your anus. It doesn't actually go doesn't become absorbed at all. And that's really interesting for medications as well. So this drug works like that. It stays just in the GI tract, doesn't really get absorbed. Laxatives, there's 2 different types of laxatives. There's a stimulant laxative, which helps moves the stool along in your system. It kind of makes all your intestinal mucosa move a little bit faster, like that. The one we use is called Senna or Senacot. it's 2 pills at bedtime, and then you wait 24 hours and see what happens, because it does take a little bit to work. If there's no improvement, you increase the dose and then reassess. And I do have some handouts that I will send along that have dose schedules, and you should always talk to your healthcare professionals as well about reassessing that kind of stuff if you do get constipated. The side effects is actually really well tolerated. You do get a little bit of cramps and nausea, and then of course diarrhea, because that's what the drug is supposed to do. There's also a laxative called an osmotic laxative, and it actually helps to make the stool stay with more liquid. So your poop is a little bit more, it keeps a liquid in your poop basically. And those are things like PEG, Restorelax, or Laxaday is the names that we usually use here in Canada. The dose is 17 grams, or one of those cups. You can just tip your bottle over and fill up your cup. Some of them come in packages as well. That is just 1 dose per package. And that's at bedtime. And then you wait that 24 hours, because the laxatives take a little bit of time to work. If there's no improvement, you increase that dose and reassess. You can actually use the 2 agents together because they work differently. And sometimes we do that for patients as well. The side effects, it's really well tolerated because it stays within your gut. It does make people feel a little distended, which is interesting. It makes you feel full, but that's just because of what it's doing. And then, of course, it gives you diarrhea. It is a little bit better for patients who have a history of IBS or problems within their guts. And that's because the stimulant laxative, as I mentioned, stimulates your intestinal mucosa. And because of that, with IBS patients, it isn't as advantageous. With PEG, you mix it with 250 mils of water or juice, not milk, because it doesn't go into solution if you mix it in milk. But any juice or water, or like things like Gatorade and stuff, you just mix it up, stir it, and it dissolves, and then you drink her down. So the non-pharm methods would be drinking at least 6 to 8 glasses of water a day for either diarrhea or constipation. That is just overall health and keeps your body in that healthy balance that we're trying to achieve all the time. For both types of bowel issues, you want to eat small meals often. Your body seems to do better with that. Avoid any trigger foods. So for example, if you don't eat a lot of spice because it gives you diarrhea, don't eat spice. You want to keep a food diary and bowel diary that's go along with that diary that I was talking about. Is very beneficial to know and track your progress. Exercising regularly keeps the bowels moving, which is important as well. And then practicing good sleep habits is also important for your bowels. Oh, there's another doggy. So do you have any questions about bowel habits and constipation and stuff, or related to other medications?
I do.
Okay.
Hi, Melanie. It's not for me. It's for a friend. They always say that. I'm fine with diarrhea. But he's got PC and he's had a recurrence and he's got horrible diarrhea, right?
Okay.
So, and he's taken various medications and he's being taken care of by a good doctor. So my question is, is the root cause, is it the cancer? Is it the chemo? Is it the medications? Is it not enough Creon? Is it the PPI? Is it his diet? Is it a potential infection and he is having a poop test? How do you know what's the root cause and how to really address it? Or is it almost a one size fits all? You kind of, this is the standard of care for this thing, and you try that first and you exhaust your options, and then we get a little more specialized and we start to eliminate things.
Yeah, so the one thing I'll speak to first is the infectious cause. So when it's infectious cause, for a patient such as someone you're talking about right now, the infectious cause that we'd always be concerned with would be C. diff. And that is a very specific type of infectious cause that happens to patients sometimes on chemotherapy. It's kind of like an opportunistic little infection.
Yeah.
So that always requires a stool test, always. And the treatment for it is antibiotics, but they're antibiotics that stay in your gut. So they don't actually go around, they stay in your gut. And there's different protocols for how long you treat, different regimens for how many reoccurrences you have. And C. diff, you know if you have C. diff because you're having really watery stools, but it has a specific smell. So if you've had it once, you'll know the smell. It has a very specific, like when we see it on our floor, you always know who has C. diff because of the smell. And it can be really quite bad for patients symptom wise, because you get really dehydrated. So we do have to give a lot of supportive medications for those patients, along with the antibiotics to treat that bug in their gut, really.
Yeah. Okay.
So that's a special one. That is like a side one.
Yeah.
The diarrhea could actually be being caused by many different things, unfortunately, and different things at different times. So yes, it can be from his treatment. 100%, definitely. A lot of chemotherapy agents cause it, and some of the ones used to treat pancreatic cancer are actually quite bad for it. It can also be the supportive medications as well. Some people have the opposite reaction to things that make you constipated. It can be the fact that his pancreatic enzymes aren't digesting the fats as much anymore. And when you don't digest the fats, sometimes you get really bloated, distended, gross bellies, but also you have a lot of more diarrhea because it comes out quite greasy.
Yeah.
So it's like a combination of issues, unfortunately. The good thing about it, though, is if it's not an infectious cause, we always treat it with loperamide.
Yeah. Yeah.
So there's just one drug pretty much.
Okay. I don't want to keep the conversation. Thank you very much. That was helpful. Thank you.
No problem. I should add really quickly, though, sometimes people who get different types of treatments also have another kind of they have an immune reaction to the treatment, kind of, and it also causes, they call them IO toxicities, and it's a toxicity to the treatment, but it's actually like you get colitis, and that requires a different treatment, not loperamide. You wouldn't use that. You'd use a different treatment, but that would be very specific to the patient and the type of treatment they're receiving for their cancer therapy. Like, it's different. We would know about it because we would know what the patient was on.
Right.
It's a very different type of diarrhea that you get. Yeah.
Thank you.
No problem. So mental health, everyone deals with a diagnosis a different way. You usually go through the 5 steps. So people feel a lot of different emotions when they receive a cancer diagnosis, and it's not uncommon to feel a lot of anxiety or a lot of depression or distress. The thing that I usually recommend for those kinds of patients is that you always start with complementary medicines or complementary therapies. And what that means is you're going to be using things like cognitive behavioral therapy, counseling, or yoga or acupuncture, or mindfulness, meditation, ensuring that you're getting the appropriate amount of exercise because that actually releases endorphins and makes your mood different. Ensuring that you're controlling all the other symptoms that you receive, that you are having because of your cancer. So that's really important to control all those things because they make for a better mind. And then you also want to allow yourself to feel the feelings and get support when you need it. So you would use support groups such as Craig's Pancreatic Cancer Society. You use your peers, you use your healthcare professionals, you lean on people. And I do find people feel sometimes this sense of being a warrior and maybe not asking for help, but that's what we're here for. And that's what we're here to do. I honestly do a lot more than just provide medication counseling for patients. I help them, talk about their process or arranging their blood work because it's a stressful experience for them, or help them lay out a calendar of what to do and when and what to think of, because getting help from others can really ease those anxieties and those feelings that you're feeling. So that's the non-pharmacological things that you always start with because they are your basis. And then you would always keep a mood diary. I'm a real proponent of keeping these diaries that allow you to look back on your days and then give a more broader view on how you're feeling. But there are medications to help with the anxiety and depression related to a cancer diagnosis. So if it's an anxiety related to a procedure, or such as getting an MRI, maybe you're claustrophobic, or every time you go get chemotherapy, it's not that you're getting nauseous and vomit. It's just it brings on a lot of emotions that you find challenging to deal with, and maybe you're feeling a little panicky. There are medications that are specifically for that, and they would be those benzodiazepines, like as lorazepam or clonazepam. And they serve a purpose. They're also they come with risks. So they do make you drowsy. They can make you kind of confused a little bit. It's unfortunate for sure, but they do serve a purpose. You can get a tolerance to them and be a little addicted to them, but if you're using them just as a needed a medication for support when you're receiving therapy or when you're experiencing a moment that's quite anxious, that's okay. To also help with the long-term anxiety and then depression, you would use agents such as they're called SRIs or SNRIs, and they're medications such as like citalopram or escitalopram, or they would be venlafaxine. So all those are antidepressants. They're classified as antidepressants. And those medications help over time. So after a couple weeks, they help you manage your emotions a little bit. I will say, and I always tell my patients, they're not going to make you feel 100%, but they're going to make it manageable. And you might notice that you start to let things go that used to make you super anxious, although some things will still make you anxious or feeling a little bit blue. So there is help. They're not going to be the cure-all of end-alls, and you have to give them time. These medications are very specific. So just like I talked about the pain management medications, that each drug can be very specific for each patient, it's the same thing for antidepressants. One antidepressant for me might not work as well for such as, let's say, Stephanie, she needs a different type of antidepressant. So you have to give them time. And then each one takes a while to work. So if you try one and it doesn't work after 4 or 6 weeks, then you try another one. Now, because they're kind of special medications, when you do take one, you have to start slow on the dose, and then you increase the dose gradually to what's called tolerated benefit. So when you're receiving benefit from the drug, you stop increasing the dose, because they're the type of drugs that you don't get a lot more benefit from increasing the dose. Once you get that benefit, it's what the drug is going to do. But if it doesn't work and you need to stop taking the drug, you have to stop taking the drug gradually as well. And you can't start taking that other drug sometimes, your new agent, until you're finished taking it. Or sometimes you can cross over, but that would have to be decided by a healthcare professional, because they're each individual, basically. They do come with side effects, unfortunately. There's quite a few of them. I'm not going to go into great detail because each agent is a little different. They can cause some dryness and stuff like that, and constipation, and a little confusion. They can cause some movement changes in your body, and they do interact with quite a few drugs. So we are all very cognizant of when we're prescribing them about what other agents you're on. But generally, they can be tolerated pretty good. People say when they first start them, they feel a little dizzy at when they start taking the dose, so we usually tell them to take them at nighttime. There are natural medicines. Once again, I don't really like that term. There are medicines that you can purchase from over the counter. People talk about using things like St. John's wort, ginkgo. Sometimes people use like vitamin B12, which doesn't really have any evidence, but sometimes people do use it. Those medications, especially St. John's wort, interacts with a lot of drugs that you're taking. So there has been, for example, a person who was taking St. John's wort and didn't know they were taking it. They had a kidney transplant. They were on transplant medications. Transplant medications interact with St. John's wort, and then they ended up losing their kidney because of it. So these natural medicines that we all talk about that are in the community, they still carry risks, and we really need to talk about them. And I am very supportive of my patients who choose to take them. I just really want to know. That's all, just so that I can make sure that they're not only effective for them and monitor them when they're on them, but also make sure that they're safe with the other medications they're on. So that's a really important underlying thing, especially because a lot of people use what's called natural medicines for mood and sometimes the pharmacists and the physicians don't know that they're doing it. So it's important to just tell us everything you take. Gives us a better picture and a better way to kind of navigate your medicines and stuff. I think that's it that I want to say about antidepressants and things for mood. Do you have any questions specifically about that? If you ask some questions, I can help you a little bit. All good? I'll keep going. So cannabis. The biggest question I get and concern I get with regards to cannabis is it okay that I use it? Or maybe someone's a little bit hesitant to tell you that they do use it because it just became legal in Canada a few years ago or a year ago or not. But for me, people have been using medical marijuana for quite some time. And I've been talking to people about it, even when I was working in cardiology, to be honest. So cannabis is a bit different. It's not a drug that is regulated by Health Canada. So there's no actual drug identification number on it, which is different for me because most of the medications I deal with have a drug identification number, or even the natural medicines have an NHP, natural health NHN or something number as well that I can use to look them up with. So cannabis is made up of a bunch of things called cannabinoids. And there's a bunch of different ones, but the ones that are the most dominant are THC and CBD. And THC has a fancy name there, and it contains the psychoactive properties of cannabis, or gives that euphoria that we all associate with cannabis and, the high basically. And it binds to those CB1 receptors that are in our bodies, those cannabinoids receptors that are in our bodies. The CBD has another fancy name, but it does not bind to those psychoactive receptors in the same way. It binds different, and we're not really totally sure, but it gives some of the same benefits as the THC without those psychoactive responses that you usually get with the drug. So you don't get that high, and it tends to help with things like anxiety, depression, and seizures. Now, specifically cannabis, its indications are a little bit specific, and like some countries don't have it legalized at all. So how people deal with it is a little bit specific to the country. But here in Canada, and I believe in the US as well, I'm not 100% positive about that. But it is used for certain things like pediatric seizure disorders. It's been shown to have benefit in people with MS and the spasticity, and maybe neuropathic pain. The jury isn't always totally agreed on all of these things, but it is being used for different things. And I think that speaks to my last point there, that there's like over 150 active trials looking at the health benefits of CBD, specifically just because we don't want to be giving everyone a drug that gives that euphoric kind of feeling. But the data is inconclusive for pain related to cancer therapy, although lots of patients use it for other reasons as well. The cannabis products that are medical grade, what it means is that it means that they're using the same plant, and they're able to tell us when it's prescribed the ratio of THC and CBD. And that's what really matters, because when you go to a place where you can buy it, say on the street or something like that, you're not really sure what you're getting, what ratio you're getting. And that's why you might get a different kind of response. The cannabinoids, those THC and the CBD is what gives it that drug property that we're talking about. And there's lots of resources. I actually have a couple more there that aren't shown on this slide, but are on my other slide. It seems like everything I worked on all week for my slides actually didn't transfer. But anyway, we have a lot of resources, great resources in Canada, and I'll share those with you guys as well. So what do people use it for? So as I mentioned, there's lots of little reasons why people use it, and maybe not a lot of evidence, but maybe it helps people specifically themselves as well. So there's neuropathic pain. People use it for anxiety and nausea, insomnia. They use it for pain. It is indicated for pediatric seizures and MS spasticity, not long-term though. And then also appetite. It comes in different formulations. It comes as a version where you can smoke it or vape it, and I would never suggest doing that. Although it is an extremely instantaneous response, it's not good because you are combusting a material, and combusting a material and putting it into your lungs is not a safe thing to do for future cancers and stuff. It comes as edibles. That response that you get from the drug is later. It's postponed, usually 45 minutes at least, around there. It comes as extracts and concentrates, and it comes as suppositories as well, which is interesting. I've never seen that, but apparently it is available. So you can get from THC, you can get dry mouth. You do get that nice relaxation feeling. That's the feeling you get from hunger. You could get euphoria and then tiredness, whereas the CBD, you get appetite changes. Actually, you get a decreased appetite sometimes. You do get fatigue, and sometimes you can get diarrhea. You can get syndromes from cannabis, which is very interesting, and people end up like vomiting profusely and requiring to be having a shower regularly, and we get them admitted for that. It's this weird reaction to smoking cannabis long term. But that's a side note. Some important things to remember is you may be impaired for up to 24 hours, so do not drive during that period. There's some concerns regarding drug interactions, because it does kind of play on one of those enzymes that breaks down drugs in our body. It does interact with one of those enzymes. So not pancreatic enzymes, but one of the ones that breaks down drugs in our body. So I am always very cautious with patients, and I look at all their medications to make sure it's safe. Although it's a theoretical interaction, we always play on the side of safety in medicine. And then you also actually don't want to use it in patients with cardiovascular health issues, because there is some worry that it could vasoconstrict some of the heart, the supportive tissues around the heart, basically. So for us in Canada, we have non-prescription versions of cannabis, which are provincial distributors, and that's different across the country. I will say in Nova Scotia, ours is all distributed through our provincial liquor commission. It's always sold in the same locations. I guess that's easy for knowing where to get it. You can also self-grow it in our country as well, up to, I believe, 4 plants. And then you can get it on the street of course, as well. Now, I will say, though, the self-grown and street, you don't know what you're getting. You don't know the ratios of THC to CBD, and you're actually using them for different purposes, THC and CBD, so it's a little bit more tricky. But you can get that medical access as well, and that comes through prescription. So at the bottom there, it says the medical access to cannabis, and that's where you would get that ratio. You know exactly what you're getting. But we also have 2 prescription products. We have Nabilone, which is a synthetic cannabinoid, and it's just the cannabinoid, and it's used for nausea and vomiting, chemotherapy-induced nausea and vomiting. It's called Sesamit, I believe. Sometimes we use it kind of as a last resort. It depends. We also have one called Sativex in Canada, and it's a spray, and that's the picture actually there. It's a spray you spray under your tongue or on the side of your cheek. It is very well absorbed and quick. Its action is very quick. It has about a 1-to-1 ratio of CBD to THC. We tend to use it sometimes for people with that MS spasticity, but also if you're a high cannabis user, sometimes and you're admitted to hospital, we get a little nervous and continue it. But it's a very expensive medication, and we're always very cognizant of that as well, about costs to the system. So I guess the bottom line is that if it is safe, so we've checked those drug interactions. We've checked to make sure that you can take it for you. Great. That's really great. I support people using it. Just really make sure you let your healthcare team know. We should know all of the drugs you take, because then we can get a really good picture of what's working, what's not working, and help navigate you through that process as well. Plus, we look for safety and stuff. So that's my last puppy. and I thought he was super cute. And this is it.
One was from Catherine, and she's saying that she tried CBD and found it affected her thinking. She became fuzzy and slow to process. What could be the issue there?
So, did she, I would require some clarification, and I apologize for that. But if it was just CBD, it can cause some confusion for sure, because it does act on some of those receptors that do cause that. You just wouldn't get the same high. So you could get a little confused. Everyone processes drugs differently. It is listed as one of its side effects, or one of its things to watch out for. Just because someone can take it and doesn't get confused doesn't mean that you can take it and won't get confused. But if it was mixed with THC, that would explain it as well. It just depends. And it would be depending if she got it from a medical distributor, so you know exactly what's in it or not.
Catherine, do you want to jump in?
Yeah, it was pure CBD, and it was a tincture under the tongue, and it was from a dispensary.
Yeah, and you found you got confused.
Yeah, and one thought was that it was maybe too high, too fast to start.
That's what I was just gonna say. Did you try going slower with your dose?
No, I just stopped.
Oh, okay. I mean, that's fair too, but I always encourage patients to do trial and error. So if I don't know what you were using for your first drop or whatnot, but if you want to try something even smaller, and see what happens. Because yes, could be too high of a dose for sure.
Okay. Thank you.
No problem.
Okay, and then Sandy wrote in saying, what are your thoughts on Rick Simpson oil, full spectrum cannabis, which has much more THC content?
So I'm not super familiar with all the cannabis different options. I'll say that up front. Since I work in hospital, I only see what patients take, because we can't provide any cannabis, medicinal cannabis or anything like that in hospital. We actually don't even dispense it for the patients. They bring it in their own, and we set them up so that they can take it their own. So I'm not super familiar with each product. From what you're saying, there has a higher THC ratio. What that would mean is that you would be getting those other benefits. So if we look back here, I'll show you. So the side effects or the effects from the THC, you would be getting those other things. You'd really get that euphoria. You will get more of that. But it does help with things like hunger. And if that's something you need, maybe you need some boost in your weight gain, right? So there's other things to think about. It's unfortunate that it causes that euphoria and not just the increase in appetite, but you also do feel tired as well, more tired. So I'm not sure what your symptoms you were trying to treat or.
Well, it's not for me. I mean, I was prescribed Nabalon by my GP as kind of preventive in case I got nausea, but I didn't. But I'm a member of a million cancer sites, Facebook sites online, right? And specifically Pancreatic. And this RSO is all the rage. And it's gotten to the point where some people actually think it's going to cure cancer. Some people rightfully take it for side effects. Some people are giving it to their 90-year-old mother and father, which scares the living daylights out of me. So, and there's no real research studies, and believe it or not, dog dewormer is now the big thing. This Joe Tippett.
Oh, I did hear about that. Yeah.
So I was just wondering if there was any actual studies that were done that at least, safely address some of the side effects that you get from the cancer, not necessarily cure you, obviously.
Yeah. So of course, I will say I don't know specifically about the side effects or about the evidence because I don't really work with cannabis that much, but I will say that if you're looking to treat side effects from the disease, some cannabis does do some of that stuff, right? Like it does help with those things, except for a product with a lot of THC in it isn't just about helping with those side effects because it also makes you feel different.
Yeah.
So for me, there's concerns around that because it's not just it's not just the side effect management that you're receiving. You're receiving a euphoric effect as well. So you can think about it kind of like benzodiazepines or Ativan. People like them because of how it makes them feel as well, right? So it's not just about the fact that it helps reduce your anxiety. It kind of gives you a good feeling. And that's where you can get, some not great reasons for taking the drug.
Yeah.
But I don't know those specific people. There's no evidence to say that cannabis is effective at all for any treatment for any cancer.
Well, have you read Jane McClellan's book, Melanie?
No, I have not. I'm sorry.
Well, if you want to learn the world of alternative treatments for cancer and getting you into remission, that's the book that is like the equivalent of a New York Times bestseller. It is all over the internet pervasively.
Nice. Okay. I'll check it out.
Sandy, what's that one called?
Jane McClellan.
Okay.
Yeah, she's got a Facebook group and she approaches the cancer Facebook groups. I mean, I'm sure there's good and bad in all of it, but I think when people take it way, way too seriously and they have a list of these alternative treatments they're taking and stuff, Melanie. It was about 20 pages long.
Yeah.
Stuff they're taking. I'm like, how do you know all the interactions, the contradictions? You're not telling your oncologist. Yeah. So like, how on earth can this be good?
Yeah, I think the thing I can encourage people the most is just to be open with what you're doing, because we need to manage risk. So I'll give you an example here of the same thing as that, people are getting holistic medicine approaches and they are getting high dose vitamin C. And that is a little bit more mainstream and they get it through intravenous. But they're doing it while we're giving them chemotherapy. And the danger in that is that when we give you chemotherapy, we're decreasing your immune system essentially for a period of time before we give you your next dose. And if you're getting an injection in that period of time, you're increasing your risk of getting infection because you're actually, giving yourself another site of infection by giving yourself an IV. So any time you cut your skin or inject something directly into your body, it could be a source of infection. So it's even something like that it comes with a risk. If you're in your nadir and your immune system is, in your boots and you decide to get an injection of something and somehow you get a bug in that site, it can be bad. So we just try to balance all that stuff out, right? So all those ideas of different types of medicines and natural products and different types of treatment and all that business, for us, we just really stick to the actual evidence.
But not just that. I was told no antioxidants, right? No melatonin, no vitamin, nothing during chemo because you're reducing the efficacy of it, right? Because one is doing one thing and the other one's doing the opposite thing. So
that is exactly right. I would say that exact same thing. So what I always tell patients is I want to support you to take the medicines that you think help you. Sometimes your chemotherapy is a short window in your treatment plan. And all I ask is that when you're taking chemotherapy, the 2 weeks before and the 2 weeks after, you don't take any other therapies than the ones we're prescribing. And that's just because a lot of these other agents do things to boost your immune system or do things to increase your risk of bleeding. And we don't want any of that stuff around while we're giving you chemotherapy. Yeah.
Yeah, but you know what, in honesty, I would like to see more integrative approaches. I would like to see the traditional medicine folks and the natural medicine folks really work more closely together and collaborate and do some real studies to prove out the efficacy and the safety, right? That would be a good thing.
Yeah, I do. I think there's like lots of room for research in those areas for sure.
Yeah.
And Mel, I just really appreciate that. I think sometimes pharmacists get a bad rep, and physicians as well, that they're just going to highlight the prescription stuff. They're just
right.
I really appreciate that every section this is what you can do. Drink the water, go for a walk, do a diary, you know, get mindfulness going as much as, right. And then there's medications that can help, but I think that's a strength that you have to say everything has a place. And also, as long as it's not a deterrent or something. So I appreciate that.
A much more holistic approach, right?
Absolutely.
Yeah, it should be a holistic approach for better health. Yeah.
Can I ask another question?
Sure.
Dehydration is very common, right? With lots of chemotherapies, very common. And while I was on mine, and mine was very toxic, I got IV hydration, right? So they would, the morning after chemo, home care would come, hook me up. I'd get 3 days for 3 hours. And how much that contributed to the fact that I had 0 side effects, plus the good meds, plus all the other diet and everything. And again, time after time, so many people are getting dehydration. Why isn't IV hydration at least part of a potential standard of care in dealing with cancer patients that are taking these kinds of chemotherapies?
Mm-hmm. So we would only hydrate someone if they okay, so this is a kind of a 2-part question. We would only hydrate someone if they're actually dehydrated, or we know that their regimen requires hydration. And that's because if you just hydrate like anyone, and they don't need hydration, you can actually mess up their electrolytes. And if you mess up someone's electrolytes, they can have heart problems because of it. And by heart problems, I mean like arrhythmias and stuff like that. So it's actually a really big deal to just hydrate someone. It also can cause blood pressure problems. There's a lot of things that can happen if you just hydrate someone who doesn't need hydrations. However, certain chemotherapies actually require hydrations, not because they're dehydrated. It requires, and they're still called hydrations because that's what they are. They require hydrations because the actual drug that they're giving you is not allowed to be in your system for long enough. So I can't say, I don't know what you got, specifically drugs you got, but for an example, we have the patients I treat in hospital, the regimens we do, that are inpatient patients, a lot of them, I should say, get a drug, and the drug is called, there's 2 agents. Sorry, it's a little complicated. One of the drugs actually can cause problems with their bladder, and it can cause kind of like bleeding of their bladder. So we give them a lot of hydrations to push that drug through their body. So we prehydrate them. We give them a big bag with the drug in it as well. And then we give them supportive therapies before and after. And then the next day, we give them another 12 hours of hydration. And we have to tell them that they need to pee every 2 hours. So it's like about getting the drug in your body, so it can go in your body, but not sit in your bladder and then gets pushed out. So there's different reasons we give people hydrations. But as I mentioned, we wouldn't just give everyone hydrations unless they needed it, because there can be risks associated with them, just like anything.
Yeah. See, in my case, because I had the Whipple procedure, right? So I was skinny, problems eating, problems drinking. I couldn't drink a lot of water because I needed my food intake. Yeah. So we knew what was coming, right? We knew I was going to be I could only take 2 sips of water a day. Not good.
Yeah. So right. Those hydrations were like supportive therapies for you.
Yeah, exactly.
Yeah, it was great. Yeah.
All right.